Perfect. Well, thank you all very much. As Spencer, basically, what I'm going to kind of go through is stuff on how to read shoulder everything, shoulder X-rays, MRI, CT scans, and then show you a lot of examples of different pathologies. Show you some examples of some case examples, some of the more complex case examples. And hopefully, just give you a nice foundation that you can sort of build on when you're looking through this stuff. Shoulder can be intimidating. It also can be pretty straightforward if you kind of break it down. Hopefully, this will kind of help you all break it down. Um, so interrupt me if you have questions. Also, we can talk more at the end. As y'all know, I'm a big fan of the shoulder joint. Wrist joint is also interesting as well, but the shoulder joint especially is fascinating. So many degrees of motion, so much force that goes through it. I mean, it's just absolutely incredible. And you think how that joint actually stays stable, how it actually functions, and how more people don't have problems. Whenever somebody sort of comes to you, these are sort of the mainstays that you evaluate it with. And sort of one thought that you can diagnose almost every shoulder pathology with a pretty good physical exam and and plain radiographs. Advanced imaging isn't always necessary. And maybe there we could do one of these talks where we do just a shoulder exam talk of just like the basics of the shoulder exam. Because I think with plain radiographs and the shoulder exam, you can diagnose most pathologies, not all, but most pathologies. So this is just a standard gray sheet. Couple of things you can see down the joint line, so you know it's a pretty good gray sheet. You can see a circle here. You know that's a pretty good gray sheet. That's the base of the coracoid. And you can see the AC joint, but you can't really see it on face. That's why you know it's a good gray sheet. So there's your joint line. In this case, you can see the tuberosity. So this is where the rotator cuff inserts. This is the articular surface. And this is the edge of the acromion right here. So the acromion is actually a posterior structure, so it's not down here. This is the edge up here. And this kind of showing you a gray sheet view. So once again, the circle here, this coming around here, versus an AP view where you can really see the AC joint right here, but you can't really see the acromion or the coracoid. This is your coracoid that sticks out here, and you can't see the joint at all. And so you can see AP views really aren't useful, right? I can't tell if this shoulder is located, dislocated. I can't tell if there's arthritis. I can't really tell much with it. All I can tell is there's some AC joint pathology in this patient. Where the gray sheet view, you can actually see down the joint. You can see there's not too much, maybe a little bit of arthritis, not too much arthritis. You can see evaluate the tuberosity, you can evaluate this acromion humeral height. So gray sheet view, a good gray sheet view is really important. That's something that we sort of stress a lot. That you don't want to see the AC joint. You want to see that nice circle where the coracoid is, and how the coracoid kind of sticks out. You want to be able to see down the joint line. These are some angles that we talk about: critical shoulder angle, TSC, or RSA angle. That's more relevant to shoulder placements, but basically looking at how much overhang there is of this acromion. These are kind of important things when we look at post-op X-rays. So it's more relevant, I guess, when you're evaluating post-op X-rays for certain factors that we're looking at. And this is sort of an important consideration when you're looking at these massive cuffs. You can see this nice arc that you see here. So it's very similar to the hip, where you have this like kind of nice even arc and a good gray sheet view. Well, you can see here, this patient loses the arc. Now, you know, it's not elevated enough where it's touching the humeral head. I mean, the humeral head's touching the acromion. So you're like, oh, this is a massive cuff. This looks pretty good, but look at there's lost the arc here. Well, when you get an MRI on that patient, it shows even more so how this is a massive cuff, and you have that loss of arc says that it's starting to elevate upwards. This is the axillary view. You always kind of want to get an axillary view, a really nice one where you can see the joint here. And the glenoid's this sort of triangle shaped structure. Here's your coracoid. Here's your humeral head. So once again, there's your triangle, there's your coracoid. That's your L, and then overlying here, if you see kind of faintly in there, that's your AC joint. You can also evaluate for subluxation. So usually the humeral head, if you drew a circle around the humeral head, this should this should split the humeral head, and this line going down this triangle should be perpendicular to the line of the glenoid. So it tells you if there's bone loss from the glenoid from arthritis. So this should be a nice symmetric view. You have a good X-ray, and you'll see with arthritis, as I'll show you in a bit, you start subluxing posteriorly, you start having kind of these funny looking tilting or bone loss posteriorly, start changing. But you can see here, this has a very nice equal distance between the circle splitting the humeral head. This is scapular Y. So this is the Y view, really nicely done. And our team at MSK at least is very good at getting a good scapular Y. But this is your scapular Y, and the humeral head should be right in the middle of the scapular Y. So your Y should be basically like a circle and almost making like a peace sign or inverted peace sign. You can see your AC joint on the scapular Y as well. And this is important because right now, if you look at the Gracie view, there's some overlap. Something's abnormal. Can't really tell. But you get a scapular Y, and you can see this patient's clearly dislocated. And you get the axillary, and you can also see this patient's clearly dislocated. And in this case, this patient has a subscapularis rupture after total shoulder replacement and like needs a revision. Basically, it's dislocated out of the joint. But just looking at this, you maybe couldn't have told this perfectly. But looking at this view, and then especially looking at this view, you can totally tell that there's some instability there. All right, so let's talk about the shoulder MRI principles. So as you look here, you have regular rotator cuff. So this is your supraspinatus slash probably part of your infraspinatus, this black line coming in here and inserting onto this tuberosity, so this flat area right here. You can see that maybe there's some changes in signal. So maybe there's some like very, very mild partial thickness tears on this guy, but for the most part, it looks pretty good. You can also see this pouch here. So sometimes they'll have a really deep pouch, and sometimes they'll have a little more superficial pouch, and these deep pouch can sometimes be a sign of instability. And then here you can see this is your superior labrum, and sometimes you'll see a little invagination in your superior labrum. We really don't worry so much about that with the exception of pictures, but that can be a source of pain and can be an indication for somebody needing a biceps tendinosis. So this kind of shows another example. So once again, you can see maybe a little bit of partial thickness rotator cuff tearing. Here's your superior labrum. This is your joint space that's sort of maintained, and this is your rotator cuff coming in. Your axial view, you can see a couple things on this. First, your different tendons. So you can see your subscapularis. So this is sort of the upper part of the subscapularis. This is a more muscular part of the subscapularis. And it's inserting onto this flat area right here. So this is the bicipital groove. This is your lateral humerus. This bicipital groove, where that little circle thing with the biceps, right next to that bicipital groove is your lesser tuberosity, and that's where this subscapularis should be inserting or should be connected to. As you go down more further on the MRI, it becomes a little bit more muscular, but you can still see your bicipital groove, and you can still see this flat area where it should be inserting onto. You can also see your infraspinatus. So this is the lower part of your infraspinatus, and then this is actually the start of your teres minor right there. But this is the lower part of the infraspinatus here, and you can see it's inserting onto this little flat area right here. So here's your joint surface, and then it stops right here. This is the part of the greater tuberosity, the lateral aspect of this greater tuberosity here. There's your biceps, as I said earlier, with the circle. Sometimes you'll see a little split tear in the biceps, or you'll see a bunch of fluid in the biceps. All signs of pathology. And then these are your labrum. So if you're doing this for instability, you can see this is usually this nice sharp structure. You can see here there's a little bit maybe posterior labral pathology, how it's not this nice sharp triangle. You can see there's a little blunting here. But this looks like a pretty good labrum. There's two nice sharp structures and no tearings that you can see. The labrum is usually connected to the capsule. And so sometimes you'll actually have a little peeling off of the labrum. Oops. Or peeling off the capsule off the labrum, but for the most part, this looks like pretty good labrum. This is another example. So once again, your subscapularis, your infraspinatus on this side, infraspinatus here, subscapularis, your biceps tendon, the joint. You can look for the joint for little subchondral cysts. If you're looking at arthritis, if you're looking at instability, once again, here's your labrum connected to the capsule here, connected to the capsule there. For all intents versus your deltoid muscles are out here. This is your conjoint tendon coming down. And then the sagittal view. This is actually really important, especially for rotator cuff pathology. It's something that we don't always get. And you always want to see this Y. And I've worked really hard, especially when I first got here, at getting all Emory sites. And I've sent lots and lots of emails to make sure this happens. All Emory sites gets the MRI back medial enough to evaluate this true Y here. This is not enough. They're not enough to really evaluate the muscle belly. You want to be able to see all the muscle bellies. So here's your supraspinatus, here's your subscapularis, here's your infraspinatus, here's your teres minor, this is your latissimus coming up here. And this kind of shows the orientation. So supraspinatus on the top, infraspinatus both on the top and the side, teres minor on the side, and then subscapularis actually is divided into two different parts, a tendinous upper part and a muscular lower part. And so this kind of allows you to see. So this is your supraspinatus, this is your infraspinatus, this is your teres minor, these are your subscapularis, triceps, and then your latissimus and teres major, and then your deltoid around the top. You can see, though, this is right at the level of the glenoid. As you go back more medially, you can see how large this infraspinatus muscle is, hence why we do the lower trapezius transfer, because it's such an important muscle. You can see the teres minor. You can see how large the subscapularis muscle is. I mean, it's massive, absolutely massive. And then you can see your latissimus and teres major, and then your trapezius over the top and your deltoid on the side. But once again, it's really important to get back there because you want to see, is there fat in these muscles, like how it's the quality of the muscle, all of that stuff. All right, I'm going to show you some principles on CT scans now. So this is a shoulder axial CT scan, probably the most valuable part of CT scans. You want to look at the joint. Obviously, this patient has arthritis. You can see a very narrow, the ball's kind of touching you can see how this ball here is touching the joint here. You can see on this side how the ball is touching the joint. And you can also see how instead of being a nice triangle, like I showed you earlier, you can see how it's almost wearing away the backside of here. So now instead of being a triangle, you're almost missing this sort of triangle of bone that's sort of missing. So this is your triangle. You can see how it's posteriorly subluxed. And you can kind of see how you're missing some, this is what's called retroversion, how you're missing some bone right here and how it's kind of pointed backwards. You can also see how it's sublux posterior. So when you draw that circle, you can see how very little of it is anterior compared to a lot of it's posterior. Here's some other examples of the coronal view, both an arthrogram and not an arthrogram. This allows you to kind of evaluate the glenoid inclination. This person you can see doesn't have this nice smooth tuberosity here, greater tuberosity. You can see how he has like a shark bite out of the tuberosity. You can see here how you have a nice kind of pear-shaped glenoid here, and you can see how there's a fleck off of that here. So that's a glenoid fracture or a anterior inferior sort of dislocation that happened in this patient. And this is the sagittal view. And then CT arthrogram, we get these if there's a prosthesis in place or if the patient can't get an MRI for whatever reason. And this once again allows you to see your rotator cuff. So it looks pretty good here, but you can see there's probably some tearing here. You can see this side looks pretty good of the infraspinatus, and that looks pretty good of the subscapularis coming in here. And it's the highlight of the dye that allows you to really see this. There's your biceps tendon, and you can see your biceps tendon going between the supraspinatus here and the subscapularis here. All right, so we're going to talk a little bit more about some detail on the rotator cuff. The supraspinatus, the one on top, has a very small footprint. The infraspinatus is the one in the back. It's a very, very large, second largest behind the subscapularis. Your subscapularis on the front divided into kind of two muscles, but it's thought of as one very large muscle, and then teres minor is a smaller one, really around the back. This kind of shows some pictures. So here's your supraspinatus coming in. This is what's called your STA ligament. It's kind of over the top of your innerl. This is your long head, your biceps tendon. That's going between your supraspinatus and your subscapularis. And then on the back side, you have your supraspinatus coming in, you have your infraspinatus here, and you have your teres minor coming around the back. So infraspinatus kind of goes around the back and it kind of wraps around the top too. So there's kind of two parts of the infraspinatus. And then the teres minor is just around the back. This is a really cool study published actually in 2008. So it's actually not that new anymore. But it really showed us that this is how they used to, the A is how they used to think about the supraspinatus. And B is actually, when you look at the anatomic dissection, this is how it actually is. Vast majority of that greater tuberosity, so that place where the rotator cuff inserts, a vast majority of it is actually infraspinatus. Only a very small part of it is actually supraspinatus. And so the supraspinatus really has a very tiny insertion, and that's why when we have a isolated supraspinatus tear, we don't get quite as worked up. The infraspinatus has a much greater function, as does the subscapularis, than the supraspinatus. And so just a small little supraspinatus tear. Now, while it can be painful, and absolutely that's an indication to intervene if it's really painful and it's resistant to a lot of stuff, there's a lot of people walking around with supraspinatus tears that don't even know they have supraspinatus tears. So then why is it that certain cuff tears cause dysfunction? You all have probably seen this, or if you haven't, you're going to see it, that there's certain people who walk around with rotator cuff tears that have just no function. They can't lift their shoulder. It's almost like their shoulder's paralyzed. Other people that have okay function, but a lot of weakness. And then other people that have things like lag signs, all this stuff. Well, there's many reasons why you have a loss of function. And really, it goes back to this force couple idea. There's an axial force couple and there's a coronal force couple. The axial force couple is really dominated by the infraspinatus, the subscapularis, and to a lesser extent the teres minor. The coronal force couple is dominated by part of the infraspinatus, part of the supraspinatus, and then the capsules, the superior and inferior capsules, as well as some of the other functions on the shoulder. So this is a normal rotator cuff. Once again, you can see the rotator coming in here, inserting on, pretty good subscapularis, pretty good infraspinatus here. Good muscle, as you can see here. So supraspinatus looks good. So does your subscapularis, and so does your infraspinatus and your teres minor. You can see this as a partial cuff tear. So this is a little articular sinus tear. So here's here's the supraspinatus coming in. You can see there's a tiny little articular sided tear here, and there's a little bursal sided tear here. So these are very small. Usually, honestly, we kind of ignore them. Occasionally it causes pain. Occasionally, we have to intervene. Vast majority of the time, not. Vast majority of the time, you can treat with injections therapy. Don't have to do a whole lot, but you can see the bursal sided and the articular side here. This is when it gets into larger tears. So you can see this is a full thickness tear. So the whole footprint is sort of torn off, and here you can see it's retracted a little bit. And this once again shows the whole footprint kind of being bare, and you can see it retracting a bit. This is another example of a full thickness tear where it's torn off and retracted a bit here, and torn off and retracted a bit here. And sort of more examples of even bigger rotator cuff tears that are torn and retracted back, and torn and retracted back. And once again, another full thickness example. So the rotator is coming in here, kind of stops there, and you can see there's just a blank tuberosity here. But you can see that the lower infraspinatus and the subscapularis looks pretty good. And here's an important consideration. This is what you would consider in a massive rotator cuff tear. So this is a normal muscle. So you can see normal supraspinatus, normal subscapularis, normal infraspinatus, normal teres minor. This has a good subscapularis, but look at the quote unquote fatty infiltration of the supraspinatus. Look at the fatty infiltration of this infraspinatus. Teres minor looks okay. Once again, fatty infiltration of the infraspinatus, fatty infiltration of this supraspinatus. Subscapularis looks okay. Teres minor looks okay. But once again, if you look at this, so these are massive rotator cuff tears that have been there for some time, and over the years have gotten replaced by their muscles have gotten replaced by fat. And you have this fatty infiltration, and so this is an important consideration because when you try to repair these, it doesn't work very well because it's now muscles being replaced by fat. There's a high chance of this re-tearing. There's been lots of studies sort of validating that. This is also kind of an interesting thing. So if you look at this, you can see a big cuff. These are two different patients with big cuff tears, some fatty infiltration here, really bad fatty infiltration of this infraspinatus here. But you can see in this case, the patient, this is your triceps here, this is your latissimus. See here, this is deltoid here. You can see here, there's no teres minor. And here you can see actually a very large teres minor. And so that's the term that we call teres minor hypertrophy. And sometimes when people have this teres minor actually gets hypertrophic and actually kind of helps to balance the shoulder. And you'll be surprised, some of these patients will have okay motion or pretty good motion. Probably weak, but pretty good motion. This patient, I can almost guarantee you, will have no external rotation of their shoulder, probably significant weakness in their shoulder, and what's called an external rotation lag, where you bring the arm out to the side and it pops right back to the stomach. Here's some more examples of the massive rotator cuff tear. So you can see the tendons are retracted back, tendons are retracted back, tendons are retracted back. So these are all signs that this has been torn and retracted for some time now. And this is one of many studies that have kind of put together. This is a multi-center study looking at a lot of these kind of factors together, these massive and what we consider irreparable or not repairable tears. When it's chronic, when it's retracted, you have short tendon length, and as I showed you, the fatty muscle infiltration of the muscle. So all negative prognostic factors. These are all signs that this is a irreparable or a rotator cuff tear that you're not going to successfully repair. You can see the retraction. You can see the narrowing of the actual tendon length. You can see this fatty infiltration as it kind of gets worse and worse and worse, as was initially published by excuse me, the Gajikali, and then eventually this was a MRI study by Christian Gerber. And this shows example, excuse me, shows example of a repairable with good muscle and a not repairable with really poor muscle. Repairable with good tendon retraction but good muscle, and not repairable with really poor muscle. Once again, good muscle on the left, not so good muscle on the right. And these are sort of really important considerations for this. And then this is a kind of interesting one. So this is where you see actually the footprint is full of tendons still. The footprint's full of tendons still, but the muscular tendinous part of this has torn off. So the muscle's torn off the tendon. The tendon's still intact here, tendon's still intact here, but you can see the muscle has pulled off this tendon and it's kind of retracted backwards. This is also kind of an interesting one. This is a subscapularis pathology. So if you look here, you have this like kind of triangle sign with the glenoid. You can see how it's subluxed anteriorly in both these cases. And you can see naturally there's not going to be that balance of that force couple on the front part. So this is an intact subscapularis, as you can see. This is a torn and retracted subscapularis. So you can see this is basically blank lesser tuberosity, and then torn back here, and then there's fatty infiltration. So this is probably an irreparable subscapularis, but this has a nice thick subscapularis on the front part. And then this also is a sign. So you can see this biceps tendon right here. Instead of sitting in this groove here, you can see how it popped out of the groove and now is sitting here right next to the shoulder, right next to the joint. That's a sign that you have a subscapularis tear, because this restraint to the biceps is torn and retracted backwards. And now the biceps is kind of sitting anteriorly here and subluxing. That's a big sign that there's a subscapularis tear. This is a spinal glenoid notch cyst. Usually you see a cyst like this on the glenoid. It's pushing on the infraspinatus muscle, or the nerve going to the infraspinatus and can cause compression. This is suprascapular notch. So this is the transverse ligament, and if you have something at this area, it can affect both the supraspinatus and the infraspinatus. And then the long-headed biceps. So I joke, but this is like the shoulder's pain generator. There's also jokes in the shoulder world that if you're French, you're biceps killer, because the French cut all the biceps. I am not French, but I am a biceps killer. I don't think the biceps is any real function, and I think people in general would do much better if they did not have a long-headed biceps. This is a nice illustration by Pascal Boulot showing this hourglass sign, and this hourglass sign where the biceps is kind of pinched on itself. And this is sort of biceps pathology. You can see the subluxation, you can see some tendonitis, and then this is like a little split tear. You can see one circle here and one circle here. And these are all signs of pathology. The exam is really how you make this diagnosis, so MRI is really not needed for most of these biceps pathologies. But I'd like to joke also, 50% of people who walk up to you in the hallway and say, hey, I have shoulder pain, or you're at a family reunion and somebody walks up to you and says, hey, I have shoulder pain. 50% chance it's biceps. So push on their biceps, examine their biceps. Probably it's going to be biceps. It might be something else, but probably it's going to be biceps. This is slap tears. That's the anchor to the biceps. The biceps inserts on the superior labrum. So If you have a slap tear and you're not a professional or collegiate pitcher, then probably it's the answer is to treat the actual biceps pathology. Here's some shoulder arthritis examples. So this is a patient where you can see some thinning of the cartilage here. So this is nice. This gray here is nice, thick cartilage. You can see how that gray disappears here. You can see this black part, the subchondral bone, is also starting to get sort of hypertrophic a little bit. And these are all the different causes of arthritis. There's osteoarthritis, there's rotator cuff arthropathy, AVN, inflammatory arthritis, post-traumatic arthritis, dislocation arthropathy, glenoid dysplasia, Charcot-arthropathy. Lots of different reasons to get shoulder arthritis. Hence why we're so busy. The most common two are the rotator cuff arthropathy and the osteoarthritis. So osteoarthritis, this is sort of classic. You can see it kind of translates backwards. You can see this goat's beard osteophyte. So you have posterior subluxation. You have this goat's beard osteophyte. You can see the narrowing of it here. There's this famous classification called the Walsh classification that Joe Walsh published, where it classifies it narrowing, but most commonly, actually, it wears away posteriorly. And this is the B1, B2. There's actually a B3, where wears away the whole kind of B part of it. So it kind of turns this half pseudoglenoid into a whole glenoid or a whole pseudoglenoid. And then you have dysplasia, which is type C, and that's a whole different sort of category. Though usually people were born with dysplasia. So this example, so 2 years ago versus now, you can see pretty well centered here, some arthritis. And then 2 years later, you can see how it's like kissing right here, and you can see how they've translated more posteriorly here. Another example, so posterior wear. So this is like a B3. So you're wearing away the whole backside of the glenoid here, wearing away the backside of the glenoid here. So this is a posterior subluxation, posterior wear of the glenoid. You can see that triangle is completely gone. You're missing a large portion of the backside of that triangle. These are some other examples where you can see the backside of the triangle is being worn away. The backside of the triangle is being worn away here. Here's your triangle. And then here you can see the backside of the triangle. And you can see these cysts that are forming. You can see the sclerosis, this white stuff right here. Little black dots are cysts, kind of sclerosis, little cysts are out here. And in general, osteoarthritis just looks bad. I mean, there's osteophytes, there's inflamed capsule, just looks like it hurts a lot. And it does, usually. Here's your goat's beards. So these are the big osteophytes down here. If you see a goat's beard, you know it's osteoarthritis. You see this posterior subluxation. You also almost always assume it's osteoarthritis there. And then once again, another example of it being wearing away posteriorly, wearing away posteriorly. You can see the value of the CT scan in this case. And so, all right, so this is another sort of pathology. This is rotator cuff arthropathy. So that we're transitioning from osteoarthritis to another pathology. And here, once again, you can see the narrowing between the humerus and this acromion, the translation upwards, and you can see that line, that kind of arc that I made. Well, this right here is no longer aligned with this right here. This right here is no longer aligned with this right here. So it's translated upwards. My classification has helped us to classify these different stages of rotator cuff arthropathy. The stage 1, stage 2, stage 3 is when it starts really getting up there. 4 when you start getting arthritis, and then 5 when you have pretty bad collapse. But this shows the example. So 5 years ago, normal looking shoulder. You can see this arch looks pretty good. And now you can see how it's elevated. So the arch is disrupted. So this right here and this right here no longer aligned. You can see there's narrowing here. And when you get the MRI, you can see how much it's elevated upwards. And so you can see the rotator cuff arthropathy now. Here's some sort of other examples. This is transitioning again to another type of pathology. So you can see kind of subtle changes here. This is the same patient, by the way. You can see progressing significantly more there, and it's progressing even more here. So this is avascular necrosis. Starts with kind of subtle changes just below the cartilage surface. Then you get this fatal crescent sign, or this not fatal, but dreaded crescent sign, where the crescent sign shows some subchondral collapse. And then you can see the humeroid actually collapsing here. Um, the this is important. You can kind of see here, it's very subtle, but you can see this line here, see this line here. And then once again, when you get the MRI, you can see pretty clearly these lines. Once again, this is AVN. This is usually very painful. AVN is usually something that's not subtle. Usually people have a lot of pain. Now, it's usually once they get to crescent time, they have pain. That's the problem, is trying to catch them early is hard. Um, and so we try to catch them early so we can do it before it collapses. That's not sort of always possible. Okay, so this is another cool one. Another type of arthritis. So you can see here this sort of medialization. You see a lack of osteophytes. And this is sort of rheumatoid arthritis. So this is where you like just it's just like gradually just wearing away this glenoid. I mean, there's no osteophytes. It's like flattening or medialization of this glenoid. Um, and you can see there's no goat's beard here, even though there's so much bone that's missing. I mean, we're at the level of the base of the coracoid here. Patient's missing so much bone. There's no triangle because the whole triangle is being worn away. But and it also look at the MRI. It doesn't look like that osteoarthritis MRI. Here, I'll go back real quick. So if you look at the osteoarthritis MRI, there we go. Look at this osteoarthritis MRI. It just looks terrible. Like so much destruction that's going on there. Look at this rheumatoid arthritis MRI. It doesn't look that bad. I mean, there's narrowing, there's bone loss, and especially for how much bone loss there is, it's amazing. But actually, there's not cysts, there's not osteophytes, no sclerosis. But it's a bad actor. These are bad actors. You have to recognize these because they're treated very differently than osteoarthritis, and they're much more challenging to treat. Here's another etiology. So this is post-traumatic. So you can see here, there's a chunk of the bone missing here, chunk of the bone missing here. This is your greater Jurassic malunion or non-union. And naturally, you can see how this is chronically dislocated when looking at this X-ray, and then you can see how it's sitting on the front part of the shoulder here. And then this one's, you can see how it's kind of chronically dislocated here. And then this one's a prior humeral malunion. You can see how it's angled. And then they've developed some arthritis from this. And so this is what I was talking about earlier, the Walsh-T. So the glenoid dysplasia. So you can see if you look at a normal shoulder X-ray versus this, you can see how there's like a loss of a neck here. So usually this extends out to here, kind of goes up like this, goes on like this. But you can see how there's like a loss of a neck here. So that's one sign of dysplasia. Another sign is there's just this like, it's almost like an oval shape of the glenoid. So here, this is a good example. Sort of an oval shape of this glenoid. And sort of oval shape here of this glenoid. And so you can see the narrowing here. You can see this oval shape of this glenoid here. And so this is, you can see the loss of the neck here, And so these are all examples of dysplasia or pretty significant glenoid dysplasia. And then this looks bad. So this could be Charcot arthropathy. It could be chronic kidney disease. Not sure. You definitely want to rule out the neck. You definitely want to rule out the any type of like bad uncontrolled diabetes. You want to rule out chronic kidney disease. Infection is an important one. So I would aspirate. I'd get a MRI of the C-spine. A variety of different ways to rule out something going on here because this is bad. Like getting this bad of shoulder arthritis is not common. All right, a couple other examples of pathologies. So shoulder instability, I think, is a cool one to sort of talk about. This shows some signs of anterior shoulder instability. You can see here, there's a little tear in the anterior labrum here. Posterior labrum looks pretty good. Here's another sign where you can see a very nice, smooth, pear-shaped glenoid here on the sagittal view. But you can see here how you're missing some of that nice circle here on the anterior side. And then here, you can see how you kind of lose this circle on the bottom of the pear. You're missing some bone here. And you can see how you're missing some of this bone on the backside. This is called a glenoid defect. This is a Hill-Sachs lesion back on the backside of the humerus. And this anterior glenoid bone loss, there's lots of discussions how to treat it, but nonetheless, recognizing it as is important because if these people have it, they probably will not be treated without surgery. Unfortunately, when you see anterior glenoid bone loss, vast majority of the time they need some sort of procedure to stabilize their shoulder if they're continuing to dislocate. This is also kind of interesting. You see here, this little thing that doesn't look like it belongs there. This doesn't look like it belongs there. And this really doesn't look like it belongs here. So this is also anterior bony Bankart. So it's basically chipped off the anterior part of the glenoid, and then the patients kind of continued to use it, and so by using it, they've kind of formed it into this ball over time. This is sort of another nice example of an anterior instability, but in this case, it's actually caused by both a subscapularis pathology. So you can see the translation anteriorly from this triangle. You can see here, you're missing some of the subscapularis on the front part here. You can see here, you have this fatty infiltration of the subscapularis. You can also see, unfortunately, that there's some bone loss here, and there's this Hill-Sachs lesion here. So that's a bad problem. We have to treat both the subscapularis problem and the bone loss problem to get this patient a good outcome. Here's another example. Subscapularis pathology, you can see basically just blank on here. So maybe some remnant tissue there, but just blank for the most part. Here's your corcoid, here's your glenoid, there's just nothing underneath there. This is important. This is an interesting, relatively rare, fortunately, but interesting one. This is your called your Hagel lesion. So it's the inferior part of this capsule. It's torn off the humerus here. So this is the glenoid part. It connects up to the humerus. This is torn off and now creates a really difficult problem they had to recognize, or you're not going to properly treat this patient. And this is in posterior instability. So see how capacious this posterior capsule is, and how it's kind of torn compared to the anterior capsule here. And this patient has a hypermobile patient that had this. And this is even more worse posterior instability. So you can see it almost looks like it's dislocated, and you can see it's like subluxed out the backside of this glenoid here. All right, so if you see this X-ray, immediately a light bulb should go off your head. We train our residents in the ER to do this. But if you have somebody walk in the clinic and this is the X-ray and they cannot move their shoulder, this is called a light bulb sign. And it means that the patient's sitting posteriorly dislocated. This patient that actually walked through, it was either Emory or Grady, I'm not sure, one of the ERs, had this X-ray. They did not get an axillary initially. The resident, unfortunately, recognized that light bulb sign, asked for a X-ray, and you can see it was sitting dislocated posteriorly. But you can see when you see the humerus with a pretty good shot of the joint, and you can see the humerus looks like a light bulb, as you can see in this case. That light bulb sign is really important to recognize. I mean, there's a posterior shoulder dislocation, really important to get an axillary, really important to make sure that gets reduced. Some other kind of things about shoulder instability. So the Kim lesion is just basically a tear off the posterior inferior labrum. These are all little names: Bennett, Glad, and Alp. So basically all forms of either some calcification that baseball pitchers can get, actual tear of the labrum cartilage, or even like peeling it off. So it was right here, and you can see it's been kind of peeled off here. Oh, this is a good one. So what's going on in these ones? Well, I mean, this one clearly looks like something's abnormal. Granted, it's not a great X-ray. You can see the AC joint here. You can see the AC joint here, but there's clearly something going on with this. This is not a terrible X-ray. Both of these were sitting posteriorly dislocated. So once again, go back, you have a little bit of light bulb sign here. This one you don't really, but it's not a very good X-ray. This one does have the light bulb sign again, and you can see both of these are posteriorly dislocated. So get an axial view or advanced imaging. If there's something that doesn't make sense and the patient has truly locked, cannot move their shoulder, which probably is actually something going on. This is a cool one. So you can see here, in general, the patient's looks pretty well centered here, pretty well centralized here, pretty good muscle here. But you can see once again, remember that Hagel lesion. You can see a pretty dramatic inferior capsule there. Proximity fracture. This may be the last one I think that I'm going to cover. There's many different ways to look at when you have a fracture, humerus fracture. In general, what happens when you fracture the shoulder, fracture the humerus? is the different bones move in the direction of the rotator cuff. So the sclera tuberosity moves upwards because the supraspinatus pulls it up in this direction. Oops. It also moves backwards because the infraspinatus pulls it in the backwards direction. You can see here, this one moves backwards because the infraspinatus is moving in the backwards direction. And when you lose the connection between the tuberosity and the head, the humeral head, this is the humeral head here. This is the humeral head here. You can see how it goes from being tilted like this to now being tilted like this. So basically loses its connection and kind of falls backwards. That's a bad prognostic factor. Once again, you can see how the head has gone backwards. You can see the tuberosity has been pulled off backwards. Once again, here's the head that's kind of fallen into valgus, and then and you can see how the tuberosity has been pulled sort of backwards. Another example: head's fallen into valgus, the tuberosity is pulled backwards. Head's fallen into valgus, tuberosity has been pulled backwards. For another good example, there's the tuberosity is being pulled backwards. The head kind of going in the middle. The lesser tuberosity being pulled in this direction, the greater tuberosity being pulled in this direction, and the head kind of falling in the middle of the two. This is a good one. So you can see here there's some bone left here, and it's dislocated. So this is the anterior dislocation. Tuberosity has stayed here. And then when you repop it back in, sometimes it actually reduces itself, but that's usually the sort of bad actor. And you can see in this case, it didn't totally. So here's your tuberosity still. Here's your tuberosity still. So it didn't totally sort of reduce itself. And you can see here, the tuberosity is now sitting off the back. You can see a shark bite out of this. There's a little glenoid bony Bankart from the dislocation, and you can see how the tuberosity is kind of sitting off to the back. And this is a bad one. So you can see proximal fracture that healed in a very malunited position, and has created sort of a very difficult problem to treat. And then this is when the greater tuberosity doesn't heal. So this is where the bone you can see here is kind of pulled off, and the shark bite out of the greater tuberosity here, and you can see how the bone's kind of pulled off to the back here. So here's a couple of case examples, and then we'll wrap things up. So case example number one, very destroyed joints, subchondral cysts, very narrow here. You can see some retroversion here, some posterior subluxation. Like you can imagine, this is probably osteoarthritis. As the rotator cuff looks pretty good, but you can see the narrowing, you see the retroversion. So yeah, this is a case of osteoarthritis. Another case example. So you can see here the rotator cuff that's torn backwards. You can see subscapularis still is intact, but you can see that this is humeral head is elevated upwards, and there's some fat infiltration in the infraspinatus and the supraspinatus. So this is kind of what we consider a irreparable supraspinatus and infraspinatus tear. Here's another good example. So this is some goat's beards here. You can see some narrowing, some wear in the posterior glenoid. So that's another example of an osteoarthritis. In this case, probably post-traumatic. You can see all that prior anchor. So probably had multiple dislocations in the past. And it's sort of another sort of nice example of the arthritis. You can see it wearing away the backside here. Biceps, your subscap, your infra. You can see how you're wearing away the backside here. You have this osteophyte here. You have the subchondral cysts underneath there. Another example of a patient. So this is a patient, pretty good rotator cuff, maybe partial thickness tears, but nothing that we worry too much about. Here's your biceps, but you can see in general, it just looks like a really bad joint. Some osteophytes, goat's beard here, a goat's beard there, and you can see some posterior wear here. You can see posterior wear of the joint here. And then this is a planning software I use to help plan shoulder replacements, and it can help you to plan out the retroversion. And then sometimes people get a loss of superior inclination, or get superior inclination from a loss of wearing the bone away a little bit superiorly. And then you can see how retrovert this is. So it's almost like pointed backwards in this case. And this is actually sublux. So there's 92% green and only 8% blue. So it's really sublux posteriorly. Another case example. So this is, you can see some anterior translation of humeral head here. When you look at the scapular Y, you can see how it's kind of translated anteriorly here. See some fat infiltration of this here and a bare lesser tuberosity. So this is an aeroparable subscapularis tear. This is sort of another example of that translation anteriorly in the subscapularis tear. Here's another example of a post-traumatic. So you can see here you have the tuberosity that's off. Here's your tuberosity that's peeled sort of backwards here. The shark bite out of the tuberosity here. Yeah, it's translated upwards because there's no rotator cuff holding it in place. The rotator cuff is connected to the tuberosity. It's translated upwards. There's a blot that this right here is no longer connected to this right here. And you can see in this case, it's the tuberosity kind of ossified in here. So that's a bad problem. That's a hard problem to treat. This is a proximal fracture. So tuberosity back here, greater tuberosity back here. This is the humeral head. And there's an example you don't want to see after a shoulder placement. Sublux anteriorly in the scapular Y. So here's your Y. It's sitting anteriorly here. You can see also it's sitting anteriorly here. So something you hopefully don't want to see after shoulder placements. And then you have this. Sarah probably remembers this person, but so what in the world is going on with this? Well, this is a patient who, unfortunately, a long time ago, had a shotgun wound to the shoulder. Very sad story, but shotgun wound to the shoulder. And basically, this is the scapula. Here's the clavicle. Here's your glenoid. So this glenoid usually is sitting right in the Y of the scapula here. This glenoid you can see is no longer in this area. You can see now it's sitting down here. And the humerus, usually sitting right across from the glenoid, is now sitting all the way down here. So once again, scapula, glenoid, humerus. So pretty bad problem. You don't see this too often, fortunately. So you can imagine there's patient probably is pretty limited, and doesn't you can imagine that didn't have a lot of options for this. So yeah, this shows it again. So scapula down here, glenoid down here, used to be up here. Now it's down here. Humerus is even further down. So humerus, glenoid used to be all the way up there. So hopefully this gives you all a baseline, shows you a little bit more complex stuff, and gets you at least thinking about some of this shoulder imaging. We covered most things. There's obviously more that we didn't totally cover, but at least gives the basis of recognizing a lot of the common shoulder pathology. I think, Sarah, if there's time at some point in the future, we should do a shoulder exam to complement this, because I do think if you have a good exam and you're able to read x-rays, you can diagnose almost every shoulder pathology, and have a pretty good idea how to treat most of it too. I think Sarah can talk about it. There is a learning curve with treating shoulders. Sarah came to me having a very good hand knowledge, but definitely I think shoulder, especially the world shoulder that we see here at Emory, is a crazy world with a lot of cool and crazy stuff that we see. So, but if you learn the basics, it's actually not as hard as it seems to evaluate. It's just something that I think takes some time to actually spend and go through MRIs, go through X-rays, stuff like that. So, any questions?
I have a question. If someone comes in with like the light bulb sign and they're like not able to move their shoulder, like what other views are you trying to order? Like,
So ideally you get an axillary. But if they truly can't get an axillary because they truly can't, they're probably locked like this. They're probably sitting internally rotated with their arm kind of either on their chest or right by their side. So potentially they can abduct a little bit in the axillary. But if they truly can't get an axillary, you can do scapular Y, and the scapular Y will show the same thing too. It's just not gonna be a little bit more subtle in the scapular Y if you can get the axillary, but the scapular Y a good scapular Y should show you what you need to see. And you'll be able to tell a locked posterior shoulder dislocation. They literally cannot externally rotate their shoulder. They'll be locked, internally rotated, usually on their chest, on their stomach, or kind of by their side. And it'll be very clear they can't move it. And you try to move it, and they'll shoot through the roof. And you'll be like, wow, they're really dramatic. And then you'll realize, no, actually, they're not that dramatic. It's actual real pathology.
Okay. Thanks.
Yeah, of course. Say, y'all have other questions? The biggest thing, I'll post this online so y'all can come back and review if you want. We have an Emory episode on YouTube. Go to that. It's an education thing, so I'll post this online. If y'all want to look at it again. My biggest advice is learning how to read any MRIs is just like dive into it, ask people, try to read it when you're looking at patients. Look at not just like what the read says. Try to actually look at the MRI before you look at the read. And then look at the read and then see if you can find what they're talking about in the read. And then ask somebody, because I'll be honest, like sometimes the radiologists are spot on and sometimes they're not correct at all, in my opinion, at least. And part of the problem with the radiologist is they're just looking at an image and you're actually looking at the patient. So you can actually evaluate where the potential pathology is and you can focus in on areas that they don't know to focus in on. So it's actually a lot easier for you to read it once you learn how to do it. And then you don't have to necessarily depend on reads. You can necessarily like I don't necessarily want to hear about what the radiologist said. I want to see the images. And every once in a while, if I see the images, really don't see anything, then I'll look at the read and see if I missed something. But vast majority of the time you don't because you're focused in on the part that's clinically relevant, and once you've seen enough, it's usually not so hard. The it becomes a little more difficult when you're doing like have implants in there. That becomes a little more challenging. You can't get MRIs obviously, or you can, but they're a little harder to read. CT scans are helpful for those. Yeah, no, I think I'm trying to think what else. Scapula problems, that's a whole nother discussion. Do get these DDR x-rays. I would encourage you to use those if you think you have a patient with a scapular problem. The shoulder DDR x-rays are just phenomenal. Maybe I should put them towards the end of the sock. I mean, they're just incredible how you can see the scapula moving, how you can see scapular pathology, how you can see glenohumeral versus scapular, all that stuff. So these DDR images are really powerful. Would encourage people to consider getting them in especially more difficult ones that you're trying to diagnose. Like I love them for frozen shoulder, and I love them for adhesive capsulitis and some massive cuff, but really those two pathologies, you can't frozen shoulder is a clinical diagnosis, massive cuff, and scapular pathologies, like scapular weaning or scapular dyskinesia is a clinical diagnosis. But now that we have DDR x-rays, we're actually trying to make it into more of an objective diagnosis. And those are really some powerful ways to do it. And one of the few centers that has this DDR stuff. So I encourage y'all to use that. The other thing you'll see a lot of is people getting referred in for rotator cuff tears on these partial thickness or maybe even small thickness rotator cuff tears. Don't get focused in on that. There's many studies out there that have shown if you image, 100 people walking down the street, 30% of them are going to have a full thickness tear, 66% or 67% are going to have a partial thickness tear. They're asymptomatic shoulder. So really common to have full thickness tears. Not a common reason to be the main pain driver. It can be, but don't focus in on that. Use a physical exam, use the history, use all the other stuff, and don't just jump right to the rotator cuff and that partial thickness tear. And we're along in the biceps. Osteoarthritis, post-traumatic arthritis, post-traumatic malunions, rotator cuff pathology, even recurrent shoulder instability. The most common reason to have pain in almost all of those, one of the most common reasons to have pain in all those is the biceps. Biceps get super pathologic in all those. And every time you move your shoulder, the biceps get irritated. So don't forget the biceps because you can always inject the biceps, ultrasound guided injection into the biceps works beautifully. And it's a really powerful way to treat patients with shoulder pain. And I would argue that is just as likely to work in an osteoarthritic patient than a glenohumeral injection. That's just as likely to work in a partial thickness rotator cuff tear as a subacromial injection. So don't forget the biceps. It's a very powerful way to treat these patients from a pain standpoint before you just jump right to surgery. So
Question for you. So, like, as a new provider, you were like talking through the MRIs. I know everyone says you'll kind of like develop your own way of reading it, but like, what view do you typically start with and then go from there when you are initially looking at an MRI, especially if you're like new to learning how to read them?
Yeah, I mean, so I guess when I was learning it, maybe I did it differently. I'm not exactly sure. But for me, I like to jump to the most relevant first, and then I like to look at the other ones as a supplement. And so vast majority of the time, when you're looking at MRI for the shoulder, the most relevant one is your coronal. So that's where the rotator cuff is. That's where you can see the joint line the best. That's where you can see osteophytes. That's where you can see some narrowing. humeral head elevation. So I jump to the coronal first. I go through the coronal, especially where I can see the infrasternus, the suprasternus, the superior labrum, the rotator cuff, the cartilage, and kind of just go through that. And if you have it in your head, whatever you want to do, I usually start at rotator cuff, then I look at the joint, then I look at the cartilage, then I look at like any other findings like the labrum and whatnot, and then some other subtle stuff like the AC joint. And then on an MRI, I'll go to the axial as the next most relevant one, because the axial is going to tell me about the subscapularis if it's a rotator problem. Tell me about maybe anterior posterior labrum if it's an instability problem. It will tell me about bone loss if it's an instability problem. Axial will tell me about maybe some retroversion of glenoid if it's a arthritis problem. And the axial on these osteoarthritis just looks terrible. So you're like, all right, this is clearly osteoarthritis. Then I go to the sagittal and I want to see the rotator cuff muscle belly for the vast majority. If it's arthritis or rotator, as long as it's not instability. Instability, you're not as worried about the sagittal. Sagittal on the you're more worried about there's a bone part. Then sagittal, I just go right to the muscle.
Okay.
And that's kind of the order I do those. A CT scan, I do it a little bit different. I do a CT scan for me, the most relevant CT scan, depending on the pathology. But most of the time, I'm looking at it for instability or arthritis, and that's axial first. I look at the axial, I get the nice triangle on the glenoid, and then I look at that, and I look at anterior posterior glenoid. I look at the subscap. I look at translation to humeral head, and then I go to the coronal, and that's when you look at sort of the joint again, and sort of the bone alignment, and then I'll go to the sagittal only if there's concern for some bone loss of the scapula. One trick I used to actually helped me a lot when I was learning MRIs or learning anatomy of the shoulder was I would often try to just go on the sagittals, and I would just go medial and lateral on the sagittals, and I would just try to name the different muscles. There's actually some softwares out there. I have to find the names of them. There's some cool softwares, free softwares out there that you can actually do that, and then you click a button, and all the muscles pop up. You can also reference what I have in the talk that labels them too. But like that was a really helpful way for me to sort of start to understand all the muscles in the shoulder. And then I could sort of like start scanning through it. And as you kind of go down on the axial, you can kind of see where you have like a tendon that goes into the backside of it. And that first tendon is kind of a long tendon. That's your infrasternus. And you go down a little bit further, that tendon kind of starts to disappear a little bit. And then there's another tendon that's kind of medial that starts coming. And that's a very short tendon. That's your teres major that comes in. You can start kind of like piecing a lot of these together as you kind of go up and down. And it gives you a 3D orientation in your head of shoulder anatomy. And that was really helpful for me, just learning shoulder anatomy by doing that a bunch. And I remember I used to like times when we were like waiting around on call or whatever, I'd play around with that software, and it was like super helpful. But I'd just play around, and then I'd see a patient in clinic and I'd play around with like scanning through these images and really trying to understand the anatomy a little bit better. So
Makes sense. Cool. Thank you.
well, just like anything else, there's a lot of this is just repetition. But it also takes like active learning. Like you can't passively learn how to read a shoulder MRI, just like you can't passively learn how to read like an knee MRI or hip MRI. I mean, that's concept of active learning where you learn something once, and then you either think about it later on, write it down some notes to yourself later on, or come back the next day and try to look at this exact same thing again and relearn it again. And then you think about it again and do it again. And you're each time trying to like push your own knowledge of like what you know. And each time you actually learn a little bit more and a little bit more. It's much different than just kind of passively going through stuff, reading the read, looking at, oh, okay, there's the rotator cuff tear. Perfect. All right, good, move on. That doesn't really give you a lot of knowledge. That's a passive way of learning. And it's not as helpful. I'm like a big believer for the residents and the fellows on this process of active learning. And I think our world is moving more and more to these ways to be active learners and to be help as a teacher, help people actively learn better. And this is a great example of that is you have to be active learning, and you can learn the stuff pretty easily. But you do have to put in a little bit of active effort. You just can't passively coast through it, or you're probably not going to learn how to read it super well. So, all right. Any other questions? Well, perfect.
I've got you gave me this like app once, Human Anatomy Atlas, and it's kind of exactly what you're just talking about, where you
Yeah.
can like scroll through the person. I put the link for it in the chat for everyone.
Awesome. Perfect. Well, thank you all very much. Sarah, like I said, I think a physical exam one would be cool. We could also do that one in person too, if you're out
Yeah,
time to do that,
yeah.
maybe just after a clinic or something like that. But for those that want, I think we could zoom in for the rest. But I think a physical exam one would be nice complement to this, just to really kind of, because between physical exam and imaging, you should be able to cover most shoulder stuff. So
Yeah, definitely.
cool. All right.
Well,
Well,
thanks,
have a good night,
Wagner.
everyone.
Thank you.
Thank you.
Bye, guys.